Hello, everyone. My name is Sean Perkins. I am the City of Philadelphia's Chief of Early Childhood Education. Thank you for joining our guidelines for childcare and early childhood in terms of your health and safety needs. We understand that this is a very important element for our children, our families, and most importantly, the staff and yourselves as you operate childcare. Thank you for all the work you do to protect the children and families of our city. We're incredibly grateful for that work. We understand this is difficult. There are a lot of things we do know and you know, and there's still some small things that we don't know. And we are trying to mitigate as much as possible the things that you do not know. A little bit of housekeeping. If you have questions throughout, please add them to the chat. I want to mute. There's so many people. There's over 140 people participating right now. We can't have 140 questions at the same time, so please do it by text. I'm now going to turn it over to Dr. Stacey Kallem from the city's Department of Public Health, who has put together this wonderful presentation for you all. Thank you again. All your work is very much appreciated. Stacey, I'm going to turn it over to you.
Great. Thank you, Sean. So nice to see you all this afternoon. As Sean said, my name is Dr. Stacey Kallem. I am a pediatrician and the director of the Division of Maternal, Child, and Family Health at the Philadelphia Department of Public Health. So I'm going to start just by echoing what Sean said with a thank you. It is a wonderful job to be a child care provider at any times, and particularly now, it's even more important. So I just wanted to start with some gratitude. Sean, I don't see the slides anymore.
Sorry about that. Try one more time.
Great. So if you can advance to the next slide. So what we'll be doing today, this afternoon, is first, I want to give a brief overview of where we are with COVID-19 here in Philadelphia, just to put in perspective where reopening childcare falls in. I'm then going to talk about some lessons from around the world, so specifically places that have reopened schools or childcare facilities long before the US did, to talk about what we've learned from those examples about child-to-child and child-to-adult transmission of COVID. And then the nitty-gritty, what I'm going to spend the most of the time on, is going over all the Philadelphia Department of Public Health guidance as pertains to childcare. So hopefully you've all got the chance to review those guidance documents. They were posted online on our website several weeks ago. So I'm going to go through the highlights and, most importantly, the rationale behind all the different recommendations that we have. And then last, I'm going to answer some questions. So I was given a few questions in advance, so I've prepared answers for those. And then, as Sean said, please type anything into the chat. And as we have time, I'll answer as many of those as I can today. And if not, we'll send out an email to follow up. So with that, next slide. So this slide you may have seen in the news. It's just showing the number of COVID cases per day here in Philadelphia since COVID-19 first hit our city back in March up until it's this Tuesday. And the reason why I point this up is I wanted to sort of contrast what's happening in Philadelphia with what you may be hearing in the news right now about other parts of the country where COVID is really surging. Thankfully, in Philadelphia, we intervened early, and you can really see that in this chart where back in April is around when we had the peak of our cases, and if you follow that blue line of number of new cases per day, it's been steadily going down. So unlike other places that are having surges, we're really on the downtrend. Now, importantly, this is not to say I can't guarantee we won't have a second wave or more COVID in the future, but what I wanted to highlight is at this moment in time, we're actually in a pretty good place here in Philadelphia, and our curve is certainly going in the right direction. Next slide. This is just to bring home that point. This slide is looking at the number of hospitalizations due to COVID every day in Philadelphia since the beginning of the epidemic back in March to the present. And similarly, it shows the same picture that mid-April and have really dramatically been going down with the number of our people in our city who've been hospitalized for COVID. Next slide. So a little bit about COVID and kids and how they are different from adults when they get COVID. So first of all, kids make up the minority of COVID cases. So here in Philly, our data shows that around 3.5% of cases are in people less than 20. And then more relevant to this audience, thinking of young kids, less than 1% of our Philadelphia COVID cases citywide are in kids 5 and younger. So really the vast majority of cases are in adults, not children. If a child does get COVID, the good news is that the research shows that they tend to have much more mild disease than adults. And then importantly, for childcare settings, they're also less likely to transmit COVID-19 to other kids or to other adults. And the next few slides, I'll talk about some examples of that. I did want to mention, just since it's been in the news a lot, in case this is a point of concern for anyone, the multi-system inflammatory syndrome in children, which is also talked about as sort of like the Kawasaki-like syndrome in children, as being associated with COVID. So that's real. It is quite serious, but thankfully it's also really, it's exceedingly rare, and most kids who develop this do in fact have a full recovery. So I just wanted to mention that in case that was an area of concern. Next slide. I want to talk about, why did schools and early childhood education centers close initially, and why do we think it's safe to reopen? So initially, when COVID first came in, there's so much we didn't know. So we were looking to other viruses, respiratory viruses that cause epidemics and pandemics, and trying to follow the same playbook. So specifically, we were looking to flu. And with flu epidemics, we know there's really good research that kids are super spreaders. That means one kid with flu can infect many, many others with flu and really drive the epidemic. And when we've had pandemic flus like H1N1, closing down schools has actually been really helpful in slowing down the spread of the epidemic. So initially, when there was so much about COVID that we didn't know, we thought, well, perhaps if kids behave like they do with flu, so they're the super spreaders, if we close down schools and places where kids congregate like ECEs, perhaps it'll make a big difference in terms of the spreading of COVID. However, the data that so far shows that, in fact, not only are kids not super spreaders for COVID, they actually seem to spread COVID far less than adults do, based on the initial research. So now, next slide, I'm just going to give a high-level summary of a few case studies from around the world, which sort of support this point that kids are not the drivers of COVID transmission to either other kids or other adults. So this first study is from Australia, from a bunch of primary schools in New South Wales, Australia, and in particular. So if you look at the graph, like each little box represents a different classroom or different exposures. The little icon on the top is the person who had COVID, and the color is whether it was a student or a staff. And then everyone below is all the different students and teachers they had contact with and potentially could have given COVID to. And you'll see on the graph that they only gave COVID to one person, that one secondary student case in red. So just the numbers, they had 6 cases of COVID across the schools, but close contact with 168 people of students and staff, and then only one of them ultimately got COVID. It's a far lower transmission rate than what we see if it was than we would typically see for COVID. Next slide. This is an example from Ireland, which is actually even more reassuring. So there were 6 cases of COVID that they were tracing. 3 were students, 3 were adults, that had over 1,000 contacts in the school system, close contacts between students and teachers. And they found 0 cases of COVID that developed in those contacts. So again, really reassuring that knocking off this idea that kids are not super spreaders for COVID. And in fact, they are less likely so far, from what we know, to transmit COVID to others. Next slide. And this one wasn't, they didn't post the full study, but there was a lot of information from Denmark, from their Department of Public Health. So Denmark did a really good job of controlling their COVID epidemic, and they reopened childcare in mid-April. And their health department, based on their analysis, stated that reopening childcare did not worsen outbreaks, it did not cause a surge, that things sort of stayed steady after reopening. Next slide. So I say all that not to say that 100% we know this is all true, because science is evolving, but I think the early science and examples we've seen from around the world is very reassuring when it comes to thinking about reopening your child care center. So now I'm going to go through our Philadelphia guidance, which is part of our safe mode, which in Philadelphia is what we are calling the yellow zone, and our framework for reopening. But before I get into that, I do want to sort of say it is not possible that I cannot 100% guarantee that you will not get a case of COVID in your center. So as long as there's no vaccine and we have COVID in our community, it is possible that your center may get a case. We believe that if you follow all of the health and safety guidance that I'm going to go through in detail, you'll be able to dramatically lower the risk of A, first getting a case in your center, and then B, if you have a case in your center, of avoiding spread to others and avoiding it being a big outbreak where there's multiple cases, if you follow the following strategies. And we've grouped our strategies amongst 5 different topics that I'm going to go through. So just briefly, it's promoting social distancing, keeping your center clean, promoting healthy habits, which is our term for hand hygiene and masking, screening, and then having a really good plan for when someone becomes sick. Next slide. So first, I want to talk about social distancing, which amongst students and children. And in children, it's really based on what we're calling a cohort model. And the whole premise is that the fewer people that you or anyone is in close contact with, the fewer potential COVID exposures, right? Because anyone maybe has COVID brewing at any time. So the fewer people you're in contact with, that reduces your risk of having getting exposed. So then for students and for children, the main idea is to limit the number of people. Oh, can you go back? I'm still on the cohort slide. Is to limit the number of people you're in contact with on a daily basis. So that means we're recommending having no more than 22 people in a classroom in keeping with the Octal certification guidelines. However, fewer is better. So if your center is able to have fewer children in the classroom and based on your staffing and your space, that will reduce the risk even further. And then importantly, kids should not then be interacting with other kids from different cohorts or classrooms. It really needs to be thought of as an isolated unit, that like sort of like a little island that doesn't interact with the other islands. Because if the kids are in separate classrooms and then sort of all intermingle in a gross motor space at the playground, they could transmit COVID to each other. It's sort of breaking down your cohort. So that's really important. I also want to talk a bit about physical distancing with young children. So we're realistic. I'm a pediatrician. I'm also a mother of a toddler. The idea of trying to keep a 1-year-old always at 6 feet apart from another 1-year-old is just not practical. So with older kids, we're recommending as much as you can, try to plan activities where there is physical distance between the kids within the cohort, but knowing that instead what's more important is focusing on hand hygiene when kids are interacting with each other. So frequent hand hygiene, and really strongly adhering to this cohort model so they're not in contact with kids from outside of their class. Next slide. So now I want to talk about promoting social distancing in staff. And this is actually a really important point, that the risk to your staff for getting COVID, they're far more likely to get it from each other, from another adult staff person, than from a child, based on what we know about transmission of COVID. So it's really, really important to emphasize to your staff that they need to be social distancing from each other, particularly to staff that are working in a different classroom or cohort. So some strategies that can help with that is staggering break and lunch hours. So staff from different cohorts aren't in a shared common room. If they are in a shared common room, moving the chairs, so there's space between the chairs. So if they're eating, which is a time they'd have their mask down, they're not directly across from each other, which is a more high risk way of sitting. And then posting some signs just to remind everyone about masking and maintaining distance. Next slide. Another time where social distancing is really important is during pickup and drop off, because you're having parents at your facility. And the rationale behind this is you want to limit close contact with parents in order to reduce just other opportunities for transmission. So our recommendations are that during pickup and drop off, parents should always be wearing a mask. If your center uses a paper-based sign in, sign out, encourage your parents to bring their own pen, so you're not passing a pen between different parents, which is a potential way of transmitting things. And also to think about strategies you can do for overcrowding or avoiding overcrowding during pickup and drop off. And how you implement this will depend on your center, but some ideas are you can assign parents staggered arrival and drop off times. So not everyone is coming to the center at the same time. If your staffing allows, we recommend actually not having parents directly escort their kids all the way to the classroom, and instead just having them be at the front door or the lobby, depending on your building, and have a designated staff person then escort the child in. And then lastly, if parents are waiting in line to check in or do a symptom screener, you can place markers or tape on the floor 6 feet apart so everyone knows where to stand to avoid overcrowding. So just some real practical strategies. Next slide. Next, I want to talk a bit about keeping the center clean. The rationale behind this, so COVID is primarily spread by respiratory droplets, meaning I sneeze, I cough, I talk. Respiratory droplets come out and then someone else breathes in or touches their face or eyes and gets those respiratory droplets. However, I can sneeze or cough and get those droplets on my hands, or they could go on a surface, and that surface can also be a place for transmission if someone else touches that surface. The good thing is if you clean that surface, you can get rid of the COVID. So we're recommending cleaning and disinfecting high-touch surfaces at least once a day, but really as frequently as you can. And by high-touch surfaces, we mean sinks, faucets, toilets, keyboards, your phone, light switches, doorknobs, all those things that people just sort of touch all the time in their daily use at your center. Also, if your center has its own playground equipment, or if you have an indoor play space that the children are using and like sort of shared toys and rotating between cohorts, we recommend that you clean that equipment or those toys between usage by different cohorts. So we're really trying to keep those cohorts distinct and not able to transmit things to each other. Also, even within a classroom or a cohort, all toys should be washed at least daily, but ideally before or after each use by an individual child if possible. And if a kid, which many young children do, puts a toy in their mouth, please remove that toy immediately to be washed. Next slide. I wanted to talk now a bit about healthy habits and first about hand hygiene. So rationale behind this is similar to surfaces. COVID is in respiratory droplets. I touch my face. I get some of those droplets on my hands. I then shake your hand. You touch your face or eye, you can get COVID. So the good thing again is that washing your hands with good old soap and water can get rid of the COVID and break that transmission chain. So you should wash with soap and water for at least 20 seconds, or you can use a hand sanitizer if your hands just don't actually look dirty. And please, if you're using hand sanitizer with children, supervise them during the use. You want to help them rub their hands until all the alcohol is dry on their hands. And just a word of caution is that hand sanitizer needs to be stored where kids can't reach it. And if a kid accidentally swallows a whole bunch of sanitizer, please call poison control for further instructions. And I put the 1-800 number for poison control on the side deck. Next slide. So now I want to talk a bit about masking. And so the basics behind masking is, again, we transmit COVID and get COVID through respiratory droplets. So I have a mask covering my mouth and my nose. My respiratory droplets are going to stay inside my mask more and less likely to transmit to you. So we're recommending that all staff should be required to wear masks at all times unless they are eating, because you can't feasibly eat with a mask on. It could either be a surgical mask that's disposable that you replace daily, or a cloth mask. And if it's a cloth reusable mask, we're recommending that you launder it every day. And then there are some actually new masks that are coming out that either have a clear cutout in the front of a cloth mask or are entirely made of clear plastic, which as we get more information about those, we will follow up and share it with you all, because I think that's a really great option, particularly for childcare, so kids can still see facial expressions and have that social emotional development. Actually, I saw a question that popped up that I'll just answer right now. Should staff be wearing masks if they're outside? Yes. So it's a quick one, really at all times, unless they are eating, wear the mask. Do not place masks on the following individuals. Anyone under the age of 2 is considered too young to wear a mask because it could be a suffocation risk or strangulation just from the cords. Anyone who actively is having trouble breathing, so if someone has asthma and in that moment is having an asthma attack, take off their mask. Anyone who requires assistance when removing the mask, so if developmentally or physically they can't take the mask off, that would be a reason. Or if children are wearing masks in your facility, they should remove the masks when they're napping. Next slide. So now I want to talk about screening and screening children and staff for symptoms of COVID-19. And the rationale behind this is really just to keep those with signs of COVID from entering your center and potentially exposing others to COVID-19. So we're recommending that all staff and the parents would be completing it for their child, should complete a daily screener, which has the following components. And I'm going to go into a lot of detail on the next slides, but just high level screening for fever, which we define as a temperature of 100.4 or higher, symptoms of COVID-like illness, which we'll discuss, exposure, and then also for children, we're recommending that centers do a quick visual inspection of the child. Next slide. So there are a few options for how you can do the screening. And I'd like to say that we just revised our Philadelphia guidance, particularly this section on it. The graphic designers are putting it all together, so it'll be on the website shortly. And what I'm telling you now is what will be reflected in that new guidance when it comes to screening. So the first option for screening is you can instruct families to do self-screening. That means you would give them a list of all the specific questions they would need to ask themselves every day, and then just sort of honor system not come to your facility if they're answering yes to any of them. And in the links, what I'll provide on the end, we have a link to what a template screener like that could look like. And this is the new part of our guidance, so it's not reflected in what's currently posted on the website. Number 2 is self-screening with reporting. So you can have your parents or your staff fill out either a paper-based, there's actually all these new apps or web-based screeners at home, but then have someone designated at your site who actually reviews the results of that screener on a daily basis. Or the last option is doing on-site screening, which I know many centers have already opted to do, where there's a designated staff person who, before someone physically comes in the building, they administer the screener on-site. Next slide. So first, I'm going to talk about fever. So the different options for fever, if you're self-screening, then you'll just tell folks to take their temperature at home and either report it back to you or they'll just sort of know if there's a fever. But I want to go through the different options for on-site. So we have 2 recommendations of how to do on-site temperature screening. The first is to use disposable thermometers. So the most common brand is called a Tempadot, which is a little strip that you can place on your forehead if you're the staff, or the parent can place on the child's forehead that reads the temperature. The pros of that is that you're not interacting with like a staff person at all, so it's really safe. The cons is you have to buy a whole bunch of them, right? Because it's disposable and daily. The other option, which is what I've seen more centers use, is using a no contact forehead thermometer on all staff and children, and then have a designated staff person whose job is to do the temperature screening. And in our guidance document online, we have a whole bunch of details about how to use the no contact thermometer in a safe way. And then I did want to point out that we are specifically not recommending using an oral thermometer for the daily screening. And that's just because even if you do your best to wash it in between when things are frantic and you're trying to get all the kids in the room, maybe it doesn't get washed as thoroughly as it can. And putting something in my mouth that goes in someone else's mouth is a really good way to transmit COVID. So we're not recommending using oral thermometers for the on-site daily screening. Next slide. So now I want to talk about the symptoms that you're going to screen for on a daily basis. There it is. So we're looking for symptoms of what we're calling COVID-like illness. So it means it's signs of COVID, but we can't definitively say it's COVID, right? Because you haven't gotten a test yet. So we're defining as the health department COVID-like illness as having a new cough or new shortness of breath, or if you have 2 of any of the following things on this list. So fever, chills, muscle pain, sore throat, or new loss of taste or smell. I want to point out that if you have a fever, you shouldn't be coming to the center no matter what, right? That's even in normal times. You shouldn't come in with a fever and should be excluded. But for COVID-like illness, it's fever plus one of these other symptoms. So fever, no matter what, you're going home, but your return to school criteria following sort of the COVID pathway is if it's fever plus one of these things on this list. I also want to point out that a kid who just has a runny nose or a stuffy nose, that's not considered part of our case definition of COVID-like illness. So you can deal with that child as you normally would for your exclusion from school. Next slide. Then you're going to screen for exposure. So this is asking every staff member and parent for a child if they've been exposed to anyone with a confirmed case of COVID-19 within the past 14 days, and then they should remain home. And the reason why it's 14 days is important, that's based on the science of COVID, that the incubation period, which is the time from when, let's say it's me, I was exposed to someone with COVID, when I could first myself develop symptoms of COVID, is up to 14 days. So if it's been 14 days since I was exposed to someone with COVID, if it's been 16, I'm now considered safe because I'm out of that incubation period. Next slide. And then lastly, just for the children, we're recommending doing a visual inspection, which I think is things that as childcare providers, you probably all intuitively know how to do, which is really just looking to see if the kid looks ill. So does the child have really flushed cheeks? Are they breathing really quickly or struggling with their breathing without having recently exercised? Are they lethargic? Are they coughing a ton? Are they having shortness of breath? If you notice any of those things in a child at your center, as you normally would, they should not be at school. Next slide. All right, so now this is, I think, where it gets a little stressful for a lot of folks is to imagine, well, what do I do if someone actually becomes sick with COVID or COVID-like illness? I want to just start off by saying that we are here to help you. You are not alone if and when this happens. And I think the next slides have our phone number a million times. So I just want to start with that reassurance is that you do not have to go through any of these decision-making processes alone. And actually, you should not be doing any of this alone. We're here to partner with you on that. So with that being said, so let's say someone has one of those symptoms of COVID-like illness, which again, I put it in the box. It's cough or shortness of breath, or two of the following of that list of symptoms. If they develop it during the day while they're at school, you should bring them to an isolation area. So this is going to either be a designated room that's sole purpose is to be your COVID isolation room, or it can be a corner of a room, if you don't have a dedicated room, where the child could be sort of seated at least 6 feet away from any other child or staff person. Now, obviously, if it's a child that's ill, there does need to be one staff person with them. The kid can't be left alone in a room. But if it's a staff member, they should wait alone until they're able to get picked up. And then you should call the parents, they should go home. We have a letter, a template of what you can send home with the child that says this is why they're being sent home, that you can check off what the symptoms of COVID-like illness were, and then also instructs them of what they have to do next. So we have the link to that at the end. So let's say you send home a children because they have symptoms. When are they allowed to come back to the center? So there's 3 different ways a child can come back to the center. And we're really recommending the first. So they could go see their pediatrician and get COVID testing. That's what we highly recommend they do, and that you should encourage your families to do, is that they should go see their pediatrician and get tested for COVID. Now, if that test is negative, they are allowed to come back to your center as soon as they meet your normal return to school criteria. So that's option 1. Option 2 is they may see their pediatrician who feels comfortable saying, based on their clinical assessment, that this is not COVID, and they write a note and say that the child is safe to go back to school. I can tell you as a primary care pediatrician, I don't think many pediatricians will be taking that option right now during COVID-19 because as we're still learning more about COVID, everyone just wants to be extra safe, but that is an option. The third option is if for whatever reason that child does not get tested for COVID, we then need to treat them as if they have COVID-19, which means following CDC and our health department recommendations for how long someone with COVID-19 needs to be isolated. So that is, they have to fit 3 different things. 1, it has to be 10 days since they first got sick and had symptoms, plus it has to be 3 days without any fever, and that's without Tylenol, without ibuprofen, like without any medications, fever-free, plus in general, their symptoms have to be improving. So that's why we're really recommending everyone with symptoms gets COVID tested, because otherwise 10 days for either your staff or a child to be out of your center, if we don't know if they have COVID or not, is a very long time. So we're recommending everyone get COVID testing as soon as they can, so then hopefully they're negative and can come back to school as soon as possible. Next slide. So now what do you do if a scenario happens where someone actually has a confirmed case of COVID-19? So first and foremost, take a deep breath and then call us. So our phone number for the Philadelphia Department of Public Health is right there. You will get connected with someone right away. We actually have a 24-hour phone number. Where after hours, we also do have someone answering the phone or on the weekends. So call as soon as you can. I'm going to tell you what the recommendations are now, but in actuality, you will be talking to someone on the phone and they will be guiding you through this. In order to make best use of that phone call and be the most efficient, it's helpful for you to have a list, like sort of the name of the person who had COVID, what their phone number is, what their birthday is, to know what classroom they were in, everyone that they were exposed to in the classroom. So as much as you have that information prepared ahead of time, that will ease the process. But if you don't, we will walk you through everything that you need. So then the recommendations that we will make at that time is that all children and staff who've come in close contact with that child, which at a daycare center will be likely the entire cohort because kids will be interacting with each other, they need to quarantine at home for 14 days. So that means they need to not be at school, not come to your center for a full 2 weeks since they were exposed to the person with COVID-19. And then if they develop symptoms during that quarantine period, they should be getting tested. Now, for the person who actually had COVID-19, they then need to stay home at least 10 days since their symptoms began, and they've been fever-free off any medications like Tylenol or ibuprofen for 3 days, and their symptoms are improving. And just something that I want to point out is that we do not require having a repeat COVID test in order to return to the center. So if I'm the individual who has COVID and I've met all these symptom-based criteria for returning to school, I do not need to show you proof of a negative COVID test to come back. Next slide. And I just want to highlight that I know some of those recommendations are a bit confusing, they're technical, and that's why we want you to call us. One of the many reasons why you should call us if that happens, so we can walk you through, based on your specific example, what happens. And then just some other recommendations is to make sure you have updated contact information for all of your staff and families. So if there is a case of COVID at your school and you need to instruct others to quarantine, you can do that rapidly. Also, you should encourage staff and parents to talk to their own healthcare providers about if they are at higher risk, so then they know, sort of can weigh for themselves the pros and cons of working at or attending a childcare facility during COVID-19. It's not up to you to make that decision. They should really be doing it with their own physician or healthcare provider. And then lastly, just to hammer it home one more time, if you think or know you had a case of COVID-19 at your center, call us. That is our phone number, and we will help you with all the next steps. We'll do the contact tracing. We will help you figure out quarantine and closure decisions. You are not in this alone. So with that, I'm going to go through some of the next slide. Oh, and these are just some resources. These are some resources that I just want to make sure everyone had these links. The first link is to our Philadelphia COVID-19 guidance. The second link is for some sample materials we've prepared for you all, which includes first a sample parent or guardian contract that you can have parents sign before school reopens. That really just says that we're all in this together. Here's what I, as a parent, will do in order to help keep the center safe too. So I will keep my child home if they're sick. I will get them tested for COVID-19 if I'm indicated. If anyone in my house is ill, I will get them tested for COVID-19. It's really just emphasizing that it's not just on the centers to keep everyone safe, but parents and guardians also have a role to play in keeping everyone safe. There's also a sample symptom screener that can use, and a sample letter to parents, as I mentioned, for if someone, can you go back, does develop symptoms of COVID. And then the last link, and I think the links aren't working right now because it's sort of a shared screen if you're trying to click on it now, so we can email out the PowerPoint. So then you can have all these links. And then lastly, the link is for the COVID-19 testing map in Philadelphia, where it's a really user-friendly map where you can type in your zip code and it tells you testing sites. So if one of your staff doesn't know where to go, or most kids will probably just talk to their pediatrician, but just in case you have that map that you can give to families. So next slide. So I know a lot of questions have come up in the chat. I'm first going to answer some questions that were emailed to me in advance, which some of them echo things in the chat, and then we'll go through everything in the chat. So keep those coming. Next slide. So the first question that I've been asked a lot about is, what about face shields instead of masks? And particularly since face shields are clear, we want our kids to see our facial expression for their development. So masks do offer more protection than shields, and just intuitively why that is sort of a mask is like tight and close to your face, whereas a shield is sort of like loose and hanging, so there's ways for air to come in and out. So our recommendation is that masks are the preferred option just to enhance the safety of your staff. That's really the reason why we believe it's better protection and will keep them safer. If the science around that changes, we will certainly let everyone know. And then as I mentioned earlier, that there are newer masks being developed that are clear. They either have a clear cutout or are fully clear that offer more protection than a facial shield, but still the benefits of seeing those social cues and facial expressions. And at the health department, we're working on doing a pilot of one of those prototypes of masks. And as soon as we have that information, and if it seems like a good option, we will send that all to you. So if you're interested in procuring. Next slide. Another question I got emailed out in advance, which I think I also saw come in the chat. It's about to be summer. It gets really hot in Philadelphia during the summer. So what happens with COVID in the water? Can we do a water play? I'm hearing a child in the background, so if we could, I love children, but if we could mute, thank you. So the answer for this is straight from the CDC, which is, and I put the link there, is that there's no evidence that COVID-19 or the virus that causes it can spread to people through water in things like pools or spas or water play areas. So really feel free to let your children have water play. That would be great. I would say that I would caution you against using a public space for water play where they'd be interacting with people outside of your center, but instead doing it like on site or with your own sprinkler. And then I put the link for CDC if you want more information. Next slide. This is something that I've also been asked about is if there was a case of COVID-19 in my center, should everyone then just run immediately? Oh, can they not hear me? I'm on mute. Too? Oh, there was something in the chat popped up that said you couldn't hear me. Sean, can you give me a thumbs up if you hear me? Great. So there was a question about if we have a case of COVID-19, should I then tell all of my staff and all of my children to go run to their doctor ASAP to get COVID-19 testing? So first of all, just to beat, I don't know what the expression is, but just to hammer it home again, you're gonna call us and then we're gonna help you. But the answer is no, you should not run out to get COVID testing right away. And that's because of the incubation period for COVID. So getting tested the minute after you're exposed, you could get a negative, but it's really just because you haven't developed the symptoms yet. So we do not recommend COVID testing in that case. Instead, everyone who's exposed should stay home and they should quarantine and monitor themselves for symptoms for 14 days. And then if they develop symptoms, then they should go get COVID testing. But importantly, I want to emphasize that you should not require negative COVID testing to return to school. So as long as it's been 14 days of quarantine and they are symptoms free, they can return to the center. Next slide. I got asked in advance and sent some news articles from Texas. And so I'm not sure if all of you have seen this, but in Texas right now, where they're having as a state a lot of surge in their COVID-19 cases, there have been some articles in the lay press about cases in daycares and early childhood education centers. So right now it's all in news articles, so I can't tell you, I haven't been able to read any sort of epidemiological studies or anything from their health department, but I'll tell you my initial interpretation of what's happening in Texas, with the caveat that it might change as we get more information. First of all, and this is an important one, is that in Texas, their government did not require their ECEs to follow any COVID health and safety guidance. They initially did, and then they actually reneged on that requirement. So I can't tell you what their centers are actually doing as far as health safety, and if they're doing all the precautions that we just outlined to reduce risk. So that's sort of number one. Number two is that these cases in Texas occurred at a time when their state is in a very different place than Philly. So right now in Texas, their curve, if you look at it, it's soaring up. Whereas I showed our sort of epidemic curve for Philadelphia is really on the downtrend. So the community-wide transmission in Texas is much higher than it is in Philly, which sort of brings me to my last point, is that the information that at least was provided to me in all the news articles I read didn't show any sort of contact tracing studies. And contact tracing is how we try to figure out who gave who COVID to know where an outbreak is coming from. So with that, I don't know if they're seeing cases in daycares and those are folks or early childhood centers. If that staff member, did they get COVID at home? Did they get it when they went to church or in their community or at a restaurant, or did they get it at the center? Without contact tracing studies, we don't know that chain of transmission, so it's hard to interpret the data. But I will tell you that I'm monitoring this situation, and we are at the health department in Texas and actually around the country and the world really closely. If there's new information or things change, we will course correct if we need to, and we'll certainly let you all know. Next slide, or that might have been the last slide. That was my last slide. So Sean, can you help me go through some of the questions that came in the chat, and feel free to add more.
Sure, of course. Again, thank you all for your participation. I saw we had 246 participants. That's quite a lot of participation. Thank you all for getting the word out. As Stacy mentioned, we will be utilizing the city's website. We'll be working with the ELRC, CPEC, First Stop, School District, PHL, Pre-K, everybody and anybody, however you receive this, you'll receive a copy of the presentation. There'll be a link. This is being recorded, so you can go back and listen in if you need to and review it. Share it with your colleagues. Make sure that you all are aware of this presentation. Thank you, Dr. Kallem, for this. So we have a few questions that came through. Again, we'll be sharing the presentation. The one that came up the most, Stacy, I don't know if you want to weigh in on, is the differentiation between fever being 100.0 versus 100.4.
Yeah, great. Thank you, Sean. And I have to say that I was alerted to this change from Octail about 30 minutes before the presentation. So I apologize if we may come out with something in a few days that is slightly different from what I'm saying now. But what I will say now is that you're in Philadelphia, and for the Philadelphia Department of Public Health, our recommendation is fever is 100.4 or higher. This is in accordance with CDC, all of their recommendations, and all of the recommendations the health department has put out for other settings like offices, healthcare. So we're being internally consistent and consistent with CDC. I don't know if Karen's on. I think she is from Octail. If she wanted to comment, we didn't have a chance to touch base on this before the meeting. So Karen, if there's anything you want to add, otherwise we will.
Can you guys
follow up. We might.
you guys hear me?
Yep.
Hi everyone. Alerted to this. So the communication that Octail put out yesterday was done in conjunction with staff at the Department of Health, at the Pennsylvania Department of Health.
It's gonna kill you.
There's lots of background noise.
You live
If
right
people
there.
could mute.
My feet and I'm tired. I'm gonna take a nap after I eat. You guys are walking
Okay,
that
I'm gonna
far.
Fix it. Hold on.
I'm maybe hearing the children in your center in the background.
I'm tired.
Okay, there we go. Yeah, so the certification staff worked with staff at the Pennsylvania Department of Health to put out the announcement yesterday, the policy statement yesterday. So I have alerted them to, and actually Amy Requa, our senior health manager, saw it and alerted them. And so we haven't been given any additional information about that. But so at this point in time, certification staff are telling folks that it should be 100 right now, and should there be any change in that, we will make sure that we communicate that out.
Yeah.
So short answer is we will be getting back to you. We acknowledge that there's a discrepancy, but it was only recently noted, so apologies.
Great. So the other questions, Stacy, can you give some update on hand sanitizer? What should that consistency be? I don't know if it's alcohol content or whatever you want. Yep.
Yeah, so it should be at least 60% alcohol of an alcohol-based hand sanitizer. So like Purell or any of those sorts of brands. And it could either be a gel, there's now liquid ones that you could spray. So whatever you're able to get a hold of.
Great. There's another question about sanitizing toys. I thought it was a great example of if a child is building a puzzle and they do not complete the puzzle or any other toy, and they want to come back the next day and use it, should they be sanitizing that puzzle on that daily basis?
Yeah, we're really recommending that every toy gets cleaned at least daily, because let's say one kid is playing with the puzzle on Tuesday, on Wednesday, someone else might want to come in and play with the puzzle and touch it. So really that all toys should be cleaned at least daily.
Great. Another one, I think it impacts more of our family care providers, but it is not just limited to them. But say you are a family care provider and you service 2 or 3 children, and they're all coming from the same home, the same household. Should they all be wearing masks?
So we're recommending that all staff wear masks, and that for children over 2, it's optional. So in that case, the staff person at the family-based center should certainly be wearing a mask. But it's up to the provider and the parents about for the children. There's one question I just saw that says it's about sanitizing. I'll just mention it. Do books need to be sanitized? The answer is no. There's been some research that shows that particular material doesn't seem to be a high touch one for COVID. So that's good news.
So another one that came through was how long should they be retaining their health screening information?
We didn't have a specific recommendation of how long you need to retain the information from the daily screener. Off the top of my head, I would say at least you should keep hold of everything for the prior 2 weeks, because like sort of the 2-week quarantine and incubation period for COVID, but we don't have a specific recommendation on that.
Right. Another one is, in particular students with exceptionalities, some of them rely on transportation. So if a child, has some problems with verbal and they have mucus, that they find mucus on them or on the bus and they're unable to communicate at the time, what should be done about that in terms of screening?
So let me see if I understand this question right. Is it if the child is being brought in on a bus, so not with a parent who can then answer the screener?
Right.
So that would be a case where I think doing a screener at home where the parent can then report in on symptoms would be really particularly useful. So either sending the child in with a piece of paper that the parent filled out about symptoms. You could then take the kid's temperature when they show up. But really, actually, for all children, if they're coming in unaccompanied, they are too young to be able to answer all the symptom screeners. So then this question should be answered in advance by the parent. Actually, Sean, there's one I want to touch on because this is an important one about the definition for COVID-like illness. So can you go back a few in the slides? This one. All right. Nope. Keep going. Keep going. Keep going. Keep going. Oh no, you're going the wrong way. Sorry, keep going forward. This one. Okay, so I want to just review again the definition of COVID-like illness because there was, I think, 2 questions that came up, and I want to just make sure it's really clear that I've explained this well. So COVID-like illness is having one of the following: cough or shortness of breath, or 2 of the next list: fever, chills, muscle pain, sore throat, or new loss or taste of smell. So for example, if I am in school and all of a sudden start coughing, please send me home. That's COVID-like illness. If I'm in school and all of a sudden I'm having difficulty breathing, that's COVID-like illness. And then if I'm in school and I start complaining to my teacher, I'm an older kid, that I have a sore throat, you take my temperature, I have a fever, so I have 2 of the following on that list, that is COVID-like illness. So if the folks who asked that question, hopefully that answers it better. And then I think there was also a question about congestion. So we followed the CDC. This is our COVID-like illness case definition for Philadelphia that we are using on all of our health alerts and really all of our settings about our case definition of COVID-like illness. And it does not include runny nose or congestion, which hopefully actually as a childcare provider will be a relief to you, because I can tell you when my child is in daycare, he has runny nose and congestion every single day. So it was purposeful in not keeping that in our case definition, knowing that there's a lot of respiratory illnesses that cause runny nose and congestion that are not COVID.
Yeah. So there's a good question that came through about the solution for sanitizing toys or disinfecting toys when there's residue left on the toys. Is there a particular potion or the solution that's used that is unsafe or harmful for children if any residue of the sanitizer is left on the toy?
Yeah, so that's one where I'm going to direct you actually to our guidance documents, because in it we have a link to the EPA approved cleaning solutions that you can use. And to be perfectly honest, I don't remember all of the names of them off the top of my head. I actually want to hone in on this one about the 10 days and the 14 days, because that's an important difference. So I think it's on the next slide. And this is getting into the difference of quarantine versus isolation. So the 14 days is a quarantine. That's what you do if you've been exposed. So let's say I work at a center and a child in my cohort has COVID, I found out. I need to quarantine for 14 days, which means stay home, not touch anyone, not come to school, and really just wait to see if I get symptoms. So that's what the 14 days, and that's based on the incubation period for COVID. So the time from when we'd expect that if I was first exposed to COVID, if I was going to get symptoms and get sick, it would happen within those 14 days. So after 14 days, I should be good. The next question was about the 10 days. So that's, I think, if you advance 1 or 2 more slides, another slide, and actually you can go to the next one. Perfect. So the 10 days is for isolation. Isolation is what needs to happen for someone who actually has COVID, or in this case, if they have COVID-like illness and did not get tested. So that's when the amount of time that you need to stay home until you're allowed to come back to school with a case of COVID. And it has to both be 10 days since you first got symptoms and 3 days fever-free off medications and your symptoms are improving. So for example, the total isolation period, depending on when your fever breaks, could actually be longer than 10 days, right? Because if you have fever for 15 days and then you're finally fever-free on day 16, it's day 16, 17, and 18. Then you've been fever-free for 3 days and can go back to school. And again, I want to emphasize, since this is technical and medical, and that is why we want you to call us, and then we will help you with each individual case, sort of hashing through these definitions I just wanted to say them in this presentation so you have a heads up of what to expect, but really don't stress too much about this. We will help you.
So that brings up a good point, Stacey. As somebody had asked about when calling the hotline, is there a list of questions that they should be prepared for? I know you rattled a couple off the top of your head, and I think they seem very reasonable. Is there a list of the things to be prepared for when you call?
We actually don't have that written out, but I think we should, and I'll work on that to put it on our website. But just to say, I'll rattle off that list again, maybe a little bit slower. So the full name of whoever was the individual with COVID-19, their birthday, their phone number, their address. Know what we're going to ask you, so if you know this in advance, that would be fabulous, is in the prior 48 hours to them getting sick, to them first having symptoms, who were they in close contact with? And then for all those close contacts, we're going to want to know their name, their phone number, their birthday, and probably their address. So we'll work on getting a list so that's easier. And I think we actually are developing an Excel sheet where you would just type all this information in and send it to us if and when there's a case of COVID. But those are the things that if you know it before you call us, that'd be great. If not, we will tell you that on the phone, and then you'll probably just call us back a few minutes later after you've gathered all the information.
Great. I think I see probably two more that need to be addressed. The first of all is on this slide that we're talking about, does the room need to be shut down immediately if someone is being sent home?
Not if someone's being sent home. If they're being sent home for COVID-like illness, for symptoms, just send them home, have them get tested. The room needs to be shut down once there's a confirmed case of COVID-19. So if you find out at 2 p.m. that, I don't know, little Johnny's mom calls you to tell you that Johnny has COVID-19, you should then call us. We'll give you instructions on who needs to quarantine, and then you'll probably have to quickly do a phone tree to all the parents and staff that were in that affected room to then quarantine.
And I saw in here, and I put it up on the screen, there's another question about the use of sprinklers and water play. Do you want to just cover that one more time?
Yeah, so for sprinklers and water play, this is from the CDC, that we don't think that the virus that causes COVID-19, which is technically called SARS-CoV-2, can be spread through water in things like pools, sprinklers, or water play areas. So please keep your kids cool, use sprinklers. I would advise that you should only use the sprinklers for kids within the same cohort. You should try to keep them physically distanced from each other if possible, based on their age and development, but that sprinklers are okay.
And just in the last 2 minutes, I've seen the questions about board games being sanitized. You know, some of those have small pieces. Should every small piece be sanitized? Should a playing board? How detailed on sanitizing for board games?
That's not one I've honestly been asked before. I would say with board games, if it's small pieces that you can just quickly throw in a bucket and just rinse them, please do. Things that are cardboard, like the board itself, you don't need to like go crazy on, but you can just do a quick wipe down. I don't think we have like much. Yeah, that's what I'd say for board games.
Yeah. I'm also seeing here water tables themselves. We clarified that sprinklers, water play fits into that.
So I think water tables are fine. If you're able to keep the children, if you have a bigger water table where the kids can be kept at a distance from each other, that would be preferred. But we don't think the water itself is at a high risk or will transmit the COVID-19.
Okay. There's a question about should there be less classroom materials. I think that that's the discretion of the teachers in the centers, right, to take these health risks into consideration. Do you have any other ideas?
So I'll just add to that for your classrooms, and this is in our guidance, the full document, I would take out all sort of like plush toys or toys that you cannot easily wipe down. So like stuffed animals or just sort of anything plush that would need to be laundered to be clean, I would recommend not having in your classroom. And then as far as, it could be helpful to have even more toys in the classroom, right? Because then if there's more toys that you can easily clean in the class, then each kid could have their own toy and not be sort of fighting with the other kid for a toy. So you'll just have to see how that works best for you, but the real recommendation is not to have the plush toys.
Yeah. There's some question about sanitize versus disinfect.
Yeah, so that's in the guidance, and when we send everything out, we have a nice slide from Dr. Paula Grabel-Nelson, our our division director for environmental health, that reviews that. So I'll add that to this slide deck so we can send it out to everyone.
Great. Sharing of information, right? If the person being diagnosed with COVID, and if they call you up, how do we handle personal information? Is that Is that being retained in some way? How are we trying to keep that secure?
That's a really good question. So how contact tracing works is, let's say I was the teacher at the center and then we have to now quarantine a whole bunch of kids. When you are calling the families to tell them to quarantine, you're not saying, oh, Miss Stacy has COVID and you need to quarantine. You will just say someone in the classroom or your child has been exposed to someone with COVID. So that's how the contact tracing works. So we don't, us at the health department, we need to know the names so we can do all the contact tracing and the follow-up. But you should not be spreading the names within your center or to your staff in order to protect everyone's health and privacy.
Right. I saw this come up is if somebody has been, if there's a confirmed COVID case, that child or the staff member, whoever has been positive, uses playground equipment. Should that be tested or should that be quarantined off? How should they handle the playground equipment that they may have used?
Yeah, so there's no testing that can be done on surfaces for COVID, but rather anything that person touched. So let's say it's a kid and they use the bathroom, and then they were in their classroom, and then they used some playground equipment or in the gross motor space. Everything that child touched should then be thoroughly cleaned and disinfected.
Great.
Specific questions on that, if and when there's a case, we will guide you through that. I want to answer this one question, is fully putting out new guidelines under green. So that's what I alluded to earlier, that we made a slight modification to the guidance that's currently posted that our graphic designers are working on and will be posting. So that will be up soon.
Great. Rugs, do they remove them from the classroom? How should those be cleaned?
We don't have a strong opinion either way about rugs. So I would say continue to do what you're doing with rugs. If you launder them or are able to vacuum them, that's great.
I think this might be I think there might be a great business opportunity for somebody out there in terms of retaining screening information. Do you know of any apps that exist for this, or is it all paper-based really right now?
There are a whole bunch of apps, I would say, on a daily basis, and my email address is public. I get emailed from different companies that are making apps and websites about various COVID-related products. There's not one in particular that I can endorse, since I haven't personally interacted with any of them, but feel free to look through it.
It's 1 o'clock now. We had scheduled this time until 1 o'clock. I'll leave the chat open and then I can retain these and then forward them to you, Dr. Stacy. So that way, if we need additional Q&As available, I think most of this is covered in the presentation. Some finer details may need to be reviewed. But thank you for your time. This is remarkably helpful. Again, we'll be sharing this out through all our networks. You can go to the city's website at phila.gov/COVID19. You will also be receiving this, like I said, through the ELLC, CPEC, PHL Pre-K school district. We'll be circulating this presentation and the recording itself widely. Be also on the lookout. Dr. Callum just mentioned that Ms. Pollock from the Department of Environmental Health is making some videos and visual aids that when the Department of Environmental Health goes in and does some evaluations of sites, those visual aids are going to be available to you as well, because I know that sometimes 5 to 7 pages of text is not as helpful as a visual aid, so we're working on that going out to you all as well. So with that, I'm going to leave the chat box open for another couple of minutes. Thank you all. Thank you, Dr. Callum. Yes, we appreciate everything that you're trying to work through.
Yeah, and thank you all so much. And again, if you have additional questions, feel free to reach out and we will try to add that to some follow-up material.
Great. Thanks, everyone.